time, I'd like to invite Dr. Mary Malapalil, assistant professor here, and she runs the fellowship program in nephrology. Mary.
Our next speaker is Ms. Susan McRitchie, who's a statistician doing program evaluation and outcome measurements at RTI International in North Carolina. She is a statistician who's a graduate of the Department of Biostatistics at North Carolina at Chapel Hill. Before that, she had a master's degree in mathematics from UCLA. Her experience is in longitudinal modeling using growth curves and statistical analysis of metabolomics data.
Thank you very much. We're very honored to be here, and we've been working with Dr. Sagi on a metabolomics project. So we're looking forward. Jessica Gooding is going to be sharing some of those results, and I'm going to sort of try to set the stage for her presentation. So first, I'd like to talk a little bit about the NIH Common Fund Metabolomics Program, and then a little bit about what metabolomics is and how metabolomics might relate to some of the quality of life issues, and some study design considerations, and very briefly, a little bit about the workflow, and then Dr. Gooding will talk about applications in nephrology. So the NIH Common Fund has been funding metabolomics work through funding research cores, training, in synthesis of standards and technology development, and through data sharing and collaboration. There's 6 research centers, RTI International, where Dr. Gooding and I work, have 1. And there's also centers at University of Florida, the Mayo Clinic, University of Kentucky, UC Davis, and University of Michigan. There's a data coordinating and repository center at UC San Diego, and they are responsible for the metabolomics workbench. And it's a great website if you're interested more in metabolomics. There's resources, there's data that you can download that's publicly available. And this is going to be a nice resource as more and more data sets are posted there, because then you'll be able to take metabolomic studies from the Mayo Clinic and from RTI and the various different people around the world and look and see what they have in common and hopefully get some new insights. There's training that's being funded by the NIH. There's a web-based metabolomics learning module that was developed by Martin Kohlmeyer at UNC that's primarily geared towards clinicians and medical researchers, and that's at metabolomicsinmedicine.org. So metabolomics involves the analysis of low molecular weight complement of cells, tissues, or biological fluids. That includes things like saliva, sweat, serum, urine. And metabolomics makes it feasible to uniquely profile the biochemistry of an individual or a system. And we're interested in patterns of change and the related metabolites, those changes that occur because of a disease or treatment. And metabolomics is being used to reveal biomarkers for the early detection, diagnosis of disease, monitoring treatments, and then one of the most important things is to provide biologic insights into the mechanisms. So we're interested in metabolomics because we know that we've been able to identify some genes that in some people increase risk of disease or their response to treatments. But these diseases and responses can also occur at the level of the proteome, and the proteins and metabolites can also inform us about the state of the disease or the response at any given moment in time. So as you all know very well, that the cells and organs in the body release metabolites that can then be measured in our serum, urine, saliva, breath, our organs, CSF fluid, and then those can be analyzed. And they can be analyzed so that we can compare different states of wellness or sickness, and it can allow us to find more sensitive and early markers of disease, or to monitor treatment, or again, more mechanistic insight. And one of the things that I thought was very interesting about this morning's talk was this, that in some people, the not going on dialysis didn't have the negative impact that was expected. So metabolomics may be able to help answer some of those questions as to which people you could not send to dialysis right away. So we know that the metabolomic signatures, which is often called the metabotype, they correlate with your gender, your race, your ethnicity, your age, your mental health, exposures to different environmental exposures, stress, your gut microbiome. So because of all these correlations, metabolomics may be actually very useful in improving patients' quality of life. So they could give you insights into things that could actually change the course of the disease progression, and that's what Dr. Gooding is going to talk about after me. And this would again be identification of very early biomarkers of kidney disease and very early perturbations in the metabolic pathways, and you could hopefully use that information to develop new treatments and interventions. Same thing for the comorbidities that are known to reduce the quality of life, such as anemia and the mineral and bone disorders. And then if you look at the individual domains of the quality of life questionnaires, you could identify perturbations in metabolic pathways that are associated with symptoms that you know are reducing the quality of life. And again, hopefully you could use this to either determine a personalized intervention strategy for someone or to develop new interventions. So we looked through the literature to see if we could find anything directly related to metabolomics and quality of life, and we couldn't. But we did find a lot of literature related to the use of metabolomics in the symptoms that are related to quality of life, such as depression, sleep disturbances, fatigue, and pain. So a couple of the papers on depression, there was a study where they looked at differences in heart failure patients with and without major depression, and another study on in older adults with and without depression. And sleep disturbances, there's actually been a fair amount that's been done about sleep deprivation in the change of metabolites. So that may be something that could be very useful for the dialysis patients. Fatigue is a very big area right now with metabolomic studies. So there was a study this year of fatigue in patients with rheumatoid arthritis. And this was an interesting one to me as a statistician, because a lot of metabolomic studies, you're looking at differences between groups. And in this case, everyone had fatigue, and they were looking at what metabolites correlated with the change in fatigue scores. And then there's also animal models that are looking at fatigue, that are trying to, these rats were exposed to trying to long-lasting stress and partial sleep deprivation to try to stimulate what people experience. And then in pain, they've tried to use metabolomics to differentiate different types of pain. And their preliminary work looks like they are able to do that. So that might be very useful in the future in pain management. And this other study used both genomics and metabolomics data to try to understand chronic pain more. So I think you'll start to see more of the omics data, hopefully, surrounding some of these quality of life issues. If you do have samples in a biorepository or from your patients that you're collecting and want to do a metabolomics analysis, the study design considerations are similar to a standard study, that you have to identify your research question. What can be unique about metabolomics is that there's untargeted metabolomics where it's purely exploratory, and there's not a lot of times where you get to just really collect samples and have a sort of a preliminary hypothesis, but you're really looking at the data to try to find out, to try to generate your hypotheses. So, and you can include clinical data, other omics data with it, and environmental exposures. Metabolomics is very sensitive, so it's important that the samples be collected and stored in a similar manner. And it doesn't require a great deal of material for an analysis. It depends a little bit on your study question and what method. But there also is one method where they use NMR, and it's non-destructive. So they can analyze your samples in a non-targeted fashion, and you can get your samples back. And this has been very useful for some of our studies where it's very hard to get those samples, and so we're able to analyze them and then return the sample to people. This is just our sort of workflow. We have untargeted and targeted. Targeted analyses, you actually get concentrations of metabolites, and the untargeted, you're trying to look at as much as possible, so you're looking at relative changes. We have panels that look at endocannabinoids, lipidomics, metals, minerals, environmental panels, and then we do different types of data analysis. We do pathway analysis. We can put in both the metabolites and the genes and proteins if we have that data. And I'm just going to skip through this part. We have different quality control procedures, which I don't think you probably care about. So, but since Jessica's going to be showing results, I wanted to just briefly mention that a couple of ways that we analyze the data. And one of the common ways of analyzing metabolomics data is through multivariate analyses. And a lot of you are probably familiar with principal component analysis, where you have very high dimensional data, so that means that there's lots more peak intensities than samples. So you may have 7,000 peaks and only 20 samples, and that from a statistical standpoint is sort of problematic, but there's ways to get around it. So when she's showing plots that look like the one on the left there, the important thing is the pattern of the dots. So each dot is an individual sample, and if you see colors that are separated, that's really good. That means that your phenotype is being well distinguished. If they sort of cross, then it means that you don't have a really strong phenotype. So what we really hope for is good separation, and then we have a program that you can identify which metabolites are causing those groups to separate, and those are your potential biomarkers. We use a statistic called, that's abbreviated as VIP, which is variable influence on projection, and that if it's greater than a certain value, we think it's important. We also use p-values and fold changes. And some of the other data analysis methods we use are descriptive statistics, hypothesis testing, and your usual linear and logistic regression. We've begun using structural equation modeling. We're getting more into integrating different types of omics data, and then pathway analyses. Thank you very much.
Before I introduce the second speaker in this metabolomic lecture series, is why did I have metabolomics staff brought here? Is because we are doing a study, of course, but the insight was given to me by Dr. Paul Kimmel. I was at an ASN meeting, and he said, you should see what they're doing, and so I walked over and watched some of the posters, and I was always interested in getting a biomarker of why people feel terrible after dialysis, or why people are depressed. I said there must be some chemical. You know, my origin is from AKI, and I said I must connect to quality of life. So I got involved, and the next speaker is Jessica Gooding. She's part of the RTI group, and she's a recent addition to a Research Triangle Institute at North Carolina, which is the RTI group. And she is a PhD, and she is a graduate from Campana Group. She received a Mentored Research Scientist Development Award in Metabolomics, a KO1, funded by the NIH. And her title was Metabolic Regulators of Insulin Secretion and Insulin Resistance. She's going to talk about the work we have been doing and to help people identify molecules that may be used as biomarkers.
Thank you so much, Dr. Sagi, for the introduction and also the invitation to be here. So I get the privilege of transitioning now to talking about how we're applying metabolomics in a number of different projects. So a lot of it is going to go fast. And then I'm going to finish with the project that we've been collaborating with Dr. Sagi and Dr. Friedman on, looking at a response to probiotics. So the first project I'm going to tell you about is a collaboration with Dr. Smoyer at Nationwide Children's Hospital, and we've been looking at steroid-resistant pediatric nephrotic syndrome with a goal of determining biomarkers that can distinguish nephrotic syndrome that is sensitive to corticosteroid treatment from those that are resistant, to hopefully allow us to diagnose that earlier and stratify patient risk, particularly to try and avoid some of these side effects of excessive and side effects of corticosteroid treatment. And beyond that, we'd like to identify pathways that are involved in steroid resistance to potentially lead to mechanistic definition of these diseases, as well as new treatment targets. So I'm just going to walk you through the methods for this one first project, so you get an idea of what we're doing. A lot of the following projects are going to be analogous to this one. So we started with citrate samples that were paired from 27 steroid-sensitive patients, 14 steroid-resistant patients, and 1 steroid-dependent patient prior to beginning treatment and after an average of 7 weeks of treatment. Those samples are diluted with saline and formate in D2O and characterized by NMR. So what you see at the bottom is 2 overlaid NMR spectra. The purple is from a representative steroid-resistant patient, and the yellow is from a sensitive patient after treatment. So you can see that there's big changes there, and part of my job is trying to figure out what all those differences are. A lot of the data you're going to see is what we call binned data, and that refers to the integration of small sections of the spectrum. We generally break this type of spectrum up into about 200 different segments. So it's a combined spectrum that doesn't necessarily refer to one metabolite by itself, but to several. And then the other kind of data I'm going to show you will be concentration fit data. So a number of these signatures that you see belong to one metabolite, and we will actually fit the signals in the spectra to determine a concentration. So that's the difference in the data I'm going to show you. So this is just a summary of the cohort demographics, just to show you that things are fairly well matched between the two. It's obviously a fairly small sample size. And then what I'm going to show you here first is the impact that the treatment actually had on the sensitive patients. And I think this is a nice proof of concept. So what I'm showing on the top is a PCA, much like Susan showed you before. And that is an unsupervised analysis. And the one on the bottom is an OPLSDA. And that is a supervised analysis. So we've told the statistical program which samples come from which groups. So it gives us a little bit more power, and that's how we actually calculate our statistics. So you can see we've actually got really good separation between the patients before and after treatment. And a number of the metabolites that are coming up in this table that I don't expect you to absorb are related to known effects of corticosteroid treatment. So we know that treatment increases overall conversion of protein to glycogen storage, and we expect amino acid turnover to occur during that process. It redistributes fat from the extremities to the trunk and face, so we expect different fats to be mobilized. And treatment also affects the hypercholesterolemia that you see in edema, and some of those signals, I think, are related to a reduction in that hypercholesterolemia. Now, if we look at the same thing for the steroid-resistant patients, we don't have the same kind of separation. This is a bad model. But this is an important proof of concept for us because we would expect minimal changes due to treatment in the steroid-resistant patients. So things are working. And then if you go and look at the distinguishing characteristics of the resistant patients from the sensitive patients after follow-up, we see essentially the same list of metabolites as before. So treatment is working for the sensitive patients, and the difference is the treatment. If you look at the concentration data, I've put the box plots up there for the distribution of the concentrations. We see a change in adipate. This is one of the molecules I can fit that reports on the fatty acids that are being mobilized. We also see a difference in creatinine and creatine concentrations at follow-up. So again, that's a report of kidney function, obviously. And so that's reporting to us that the treatment is working. You guys know that. If we look at what changed over the course of treatment, we see this big change in adipate that also correlates with other parts of the spectrum that I can't fit related to lipids. And we see a change in pyruvate between the two patients. Pyruvate is highly utilized by the kidney and may play a protective role during kidney injury. So I think this is a really interesting pathway to look at moving forward in these patients. Now, the question we really wanted to answer was, can we tell the difference between the two at baseline? And the PCA for our bin data, not really good. But when I go through and fit the compounds that I can, what we found are significant differences in betaine and creatinine concentrations between the steroid-sensitive and the steroid-resistant patients at baseline. So creatinine, as you know, is an important marker. Betaine is metabolized in the kidney for osmotic regulation. So I find it very encouraging that it seems to be reporting specifically on kidney function. And we'd like to move forward doing more statistical analysis to evaluate whether this can actually improve classifications of patients beyond, say, our classic risk markers of patient age at presentation and the like. And then we'll need to validate that, and this goes for other studies that I'm going to show you, in an orthogonal quantitative assay as well as in a separate cohort. We have collaborations ongoing with a proteomics core, and we would like to integrate that data that's showing some promise already as well, and then follow up with some with some mechanistic studies to actually show why, say, betaine may be changing in the process of steroid-resistant nephrotic syndrome. So the next study I want to tell you about is a collaboration with Patrick Brophy and David Ashkenazi at the University of Iowa and Alabama Birmingham, respectively. This was a study in preterm neonatal urinary development and AKI. So this goal of the study was to help define early AKI prior to changes in serum creatinine and allow early intervention that could positively impact health outcomes in the neonatal population. And as you might imagine, the neonatal population is a particularly challenging one because preterm neonatal population is a particularly challenging one because the kidney's in different stages of development. So we also have this dynamically changing system. What we were able to show after analyzing urine from diapers is that we could separate AKI from normal neonates. We have a list of metabolites there. Among the top hits, tyrosine metabolism is particularly interesting, as well as hippurate and lysine. They've all been mentioned in the literature as either being implicated in acute kidney injury or in insufficient growth in utero. One of the things that we noticed as we were analyzing this data is that there was a difference in pH. So the peaks in the NMR spectrum will actually shift depending on the pH in the tube. And the pH was actually pretty good at stratifying these samples into groups. However, when we look at the ROC curves for pH and then compare that to the scores from the rest of the metabolites in the OPLSCA, we were able to show that the metabolites do a much better job of predicting it, the group. Now, when we looked at gestational age, we were also able to determine some markers that correlated with gestational age. We fit two models here. The one on the left is for AKI, or no AKI, on the right for AKI. And again, there's a series of metabolites associated with these models, and we can put that into a pathway mapping analysis and found that aminoacidacyl transferase biosynthesis is one of the most enriched pathways in this. And this is particularly interesting because it has also been noted in studies of urine in newborn rats administered aminoglycoside to induce AKI. Hydroxybutyrate was another metabolite that came up as being significant between in the model. And animal studies have shown that chemical-induced renal toxicity actually demonstrate a protective effect for hydroxybutyrate in the rat kidney. So not only can metabolomics show you what's going wrong, but they can also show you the compensatory responses of the system and things that may be actually protective to the system. We did another study with Snezana Petrovic looking at predicting diabetic nephropathy progression. It used this set of samples from the African American Diabetes Heart Study, and we compared urines from a number of early CKD stage patients. I'm going to kind of skip forward through this. What we were able to find two models, one looking at just progressors versus stable CKD, and another looking at fast progressors versus CKD. and again found a particularly informative model. And the metabolites that stick out to us in this result are actually branched chain amino acids and keto acids. And branched chain amino acids are known to be associated with future diabetes up to 12 years before a diagnosis of diabetes. And they seem to also be informing us about the progression of kidney disease. So that I would love to follow up on that more. Again, we have lots of validation studies to do moving forward. I met some of you last night, and I think there's particular interest in the room in anemia and erythropoietin treatment, so I wanted to highlight this project real quick. It's with Michael Merchant and Michael Breyer at the University of Louisville. And we were interested in determining if metal concentrations were correlated with anemia or response to erythropoietin treatment, with the goal of developing more objective approaches to dosing ESA agents. So the study was in EDTA plasmas from 110 dialysis patients. 77 of them were prevalent, 33 incident, and we measured markers of anemia alongside a panel of 14 metals. So one of the major patterns that arose in the data was the difference between incident and prevalent patients. And you'll notice also on the right are just plots showing the percent of total frequency for incident patients that actually were treated with EPO or their ERI index versus those that had non-zero. And there are big differences between the two. So the difference in prevalence and incidence explains much of the variance in the metal concentrations, and they're significantly associated with the anemia. So the metals in particular that are associated with this are cadmium, manganese, tin, nickel, molybdenum, and also vanadium. Cadmium, nickel, and vanadium have all been found at higher concentrations in multiple cohorts of dialysis patients, and manganese has been found to be deficient in multiple cohorts. So this is consistent with the literature. Because of the big influence of incident versus prevalent on the data, we decided just to look at the prevalent patients to look at correlations. And what we're finding, I don't know if you can read the metals on the screen, but what we're finding is cadmium in particular is correlated to hemoglobin, EPO dose for the month, and ERI. So there's a lot more information on the screen, but I wanted to highlight for you, again, that cadmium accumulation has been associated with iron deficiency in multiple studies, and then if you move into animal studies, cadmium exposure has been found to cause anemia by reducing older erythrocyte counts and bone marrow erythroid cell production, and seems to cause renal anemia first before these other potential causes like hemolysis and iron deficiency through competition and renal damage. So we're learning a lot from that study still. So I think that it could be very interesting for developing new strategies, maybe other dialysis modalities that would be more effective in, say, removing cadmium that could really have an impact. So from there, I want to take a bit more time to go through our study with Dr. Sagi, Dr. Friedman, looking at the response of patients to probiotics. I think Dr. Freeman did a really good job earlier of introducing the study. Our samples were derived from, this is again going to be NMR metabolomics of plasma samples from a cohort of 24 patients who participated in a 4-month dose escalation study of the probiotic supplement Renadil. Those probiotics contain 3 specific strains, S. thermophilus, L. acidophilus, and B. longum. The goal of the study was to evaluate alternative strategies for preventing or delaying the initiation of dialysis, in particular determine if there is a metabolite pattern associated with the improvement in CKD response to probiotic treatment. This is a summary of the clinical study data. In this particular study, the only clinical measurement that changed significantly across the study population was a change in BUN. This is consistent with a previous study of the same probiotic that found BUN was the measure of kidney function most affected by the same probiotic. And it's also consistent with the probiotic strategy of including urease-producing strains in an effort to increase the degradation of urea. So for our study, we divided the samples into 2 groups based on how BUN changed in response to the treatment. So for responders, we considered people who had a BUN that decreased over the 4-month time period in response to the probiotic, and for the non-responders had an increase or stayed the same over time. And the demographics are well matched. The only characteristic that was different between the 2 groups statistically was age. I'll show you that distribution in a minute. BUN was actually significantly lower in the increased BUN group at baseline, and there was no difference after the 4-month trial. And again, we selected the 2 groups based on a very significant difference in the change in BUN. And then in panel D is the distribution of age. So you can see we have a few outliers in the decreased group, which I think is really just driving that effect. Okay, so we did end up with a very good separation in the PCA and OPL-SDA and found a significant set of metabolites. Those metabolites map to a number of pathways. I'm going to get back to these pathways a little bit, but I just wanted to highlight in this table, these pathways have been associated in the literature with both microbial metabolism as well as renal function. So we do think it makes sense that we'd see these metabolites in a study of the gut-kidney axis. One of the things we were concerned about based on the difference in BUN at baseline was maybe the pattern we were seeing is just reflecting a difference in kidney function at the beginning of the study. So we also looked at the difference between people with CKD stage 3 and those with CKD stage 4. There was one person who was stage 5 after qualifying for the study that got grouped into. And we see a different pattern of metabolites as a result. And this is just a list of the different ones, the ones that were different between the two groups. And really, the pathway that sticks out to us here is choline metabolism. So this is just a diagram of choline metabolism. And in the red boxes are the metabolites that we measured as being different between the responders and non-responders at baseline. So we have very good coverage of this pathway, and it seems to be changing, or seems to be dramatically different between the responders and non-responders. Sorry about the wall of text. There's a lot of references in there. The kidney synthesizes the osmolytes betaine and glycerophosphocholine, which are both derived from choline, to retain water and respond to changes in tonicity. So there's a kidney-specific response in those metabolites. Choline deficiency is associated with damage to the kidney, as you might expect from what I just told you. And it also is associated with changes in gut microbial ecology, so your gut microbes are also using it. Due to its metabolism in the proximal tubular cells, some have hypothesized that elevated plasma choline may reflect tubulo-interstitial dysfunction, which is as you know, a pathology that it's even more highly correlated with CKD prognosis than glomerular injury. Trimethylamine and dimethylglycine are known uremic solutes, and the metabolism of choline by the gut microbiome is a major contributor to their synthesis. In particular, the presence of dimethylglycine in the intestinal lumen has been positively correlated with the presence of Enterobacteriaceae and negatively with lactobacillus species. So these are pieces in the literature that we're pulling together, and we would have to do a mechanistic study to really confirm that this was going on in these patients, but I think we have a really good story coming together here. So with that, I'd like to acknowledge our group, in particular, Kelly Mercier has run a lot of the NMR data you just saw. And I won't go through the whole list, but everyone has contributed to these projects. And also acknowledge the NIH for the funding that supported this work. And again, Dr. Sagi and Dr. Freeman for the opportunity to work on these samples. It's been a great pleasure, so thank you.
Wait for your slides. It is my pleasure to introduce Dr. Mark Unruh, who is an associate professor from the Department of Internal Medicine. He is the chief of the Division of Nephrology in Albuquerque, New Mexico. He is a renaissance man in the field of nephrology research and well known for his contributions in quality of life as well as in sleep disorders, as well as a friend and colleague on some projects that we're working on.
Thank you for the introduction. I want to say that unlike Dr. Kimmel, I haven't been pestering you for a decade to get to visit, but it really is an honor to visit here, an institution that's had such a seminal role in the past of nephrology as well as the future. So I want to thank you for the invitation. And I will talk about all the people at RTI. Are there any good stories about these folks? There might be. There you go. Yep. And, I was given the task to talk about dialysis frequency and home dialysis and how it relates to quality of life. And I did take some liberty in that I sort of expanded the topic to kind of talk a little bit about where we are with in-center hemodialysis thrice weekly, as well as more frequent dialysis. I have no relevant financial disclosures. And, I thought that this quote from Lemke, who is a New Yorker, was in the New York Department of Health and a leader in sort of the assessment of, one of the initial pioneering leaders in the assessment of outcomes, was very telling when you think about the frequency of dialysis. It's not, how well or how frequently the medical service is given, but how closely the result approaches the fundamental objectives of prolonging life, relieving distress, restoring function, and preventing disability. So, instead of process outcomes, maybe we should focus on the outcomes that are important to patients. And for us, on our journey, we're going to talk a little bit about thrice weekly in-center dialysis, frequent hemodialysis, home dialysis, infrequent dialysis, as well as the clinical implications of these findings. So why are we talking about this? Are we satisfied with how we're doing with thrice weekly hemodialysis? It's already been outlined that it's very costly care. The annual mortality rate is 1 in 5 or maybe 1 in 6. And when you compare to the general population, at least, there's a markedly diminished quality of life. Why is this? Is it that we're not treating comorbidities or symptoms that we should? Is it a failure of the healthcare system? There was a nice expose of sorts by Robin Fields in The Atlantic talking about sort of the perverse incentives that exist in for-profit dialysis. As a nephrologist, everything is due to uremic toxins, so it's really terrific to follow the metabolomics group. Are we failing to cure uremic toxins with thrice weekly hemodialysis? Or is it that we're failing to personalize our care, to find out what really matters to our patients and address those concerns? So just as a reminder, we've talked a little bit about health-related quality of life. Overall, no matter if you measure it with one item or many, it's thought to include domains related to physical, mental, emotional, and social functioning. These are just some nice figures demonstrating the relative decrements of quality of life using the sort of routine tools compared to the general population. And when you look at the physical domain of quality of life, you can see that the population we take care of has as large a burden as any other chronic health condition. When you're looking at the sort of mental well-being of the patient, there's a substantial decrement compared to other chronic health conditions. Not as severe as depression, but to me that sort of gives it some sort of face validity. There's talk about the fact that we maybe haven't improved quality of life of our patients, and I would suggest that the data support this. This is data from the DCI sort of SF36 data over the past decade, and what this demonstrates is a straight line. So there's really no substantial change in quality of life in either physical or mental well-being over the past decade. And I'll note, like Dr. Kleiger pointed out, over that same period of time, there was an increase and then a decrease in the hemoglobins. There's been an attempt to reduce phosphate. There's been a change in how we give patients dialysis or how adequate our dialysis is as measured by KT/V. And yet, when you look at these lines, there really hasn't been a huge impact in quality of life. So is this how we're measuring quality of life, perhaps? Is it how frequently we're measuring quality of life? This is reflecting sort of the CMS mandated annual measures. If we measured it more frequently, would it look better or would it look worse? Or is it that we've sort of reached the threshold of what we can do in the current medical system with thrice weekly hemodialysis? So, other folks have looked at different frequencies in measuring quality of life. This is in a PD population, measuring it every 6 months, and over time there was a little bit of a decline. When Mittal et al. Looked at it every 3 months, there was an initial decline, and then it was relatively stable. Of note, in all of the studies, largely, there's an issue of what to do when someone passes away, what sort of quality of life does that reflect? And neither of these studies really address that. Our groups looked at sort of more frequent assessments with the notion of getting at post-dialysis fatigue and changes in the day. And we've used the diary approach to look at sort of mood, alertness, and sleep from a day-to-day standpoint, and that is shown in this paper by Romoliotti, which demonstrated that the dialysis, the end-stage renal disease group, not only had lower scores, but also had more day-to-day variability. Not being satisfied with daily measures, we went and we asked patients 4 times a day how they were feeling. And in particular, we focused on fatigue, sleepiness, and exhaustion. And when you looked at that, there was not only a sort of a morningness to eveningness increase in fatigue and exhaustion, which you'd kind of expect, but there was also a day-to-day variability with those who were on their dialysis day reporting more fatigue, sleepiness, and exhaustion. So in general, no matter how you measure it, whether you measure it annually or every day, the population we take care of definitely has challenges when it comes to overall quality of life, and there's really not been a huge movement in quality of life as we measure it over the past several decades. So, are we actually measuring what's important to our patients? And, this is work that is currently ongoing in New Mexico, and I just wanted to briefly mention it because it ties in with some of the previous speakers as well as some of the rationale for changing up the frequency of dialysis. So in our population, we noted that quality of life is measured usually using these standard tools, the SF36 or the KD-QOL. Really, it's unclear how much that reflects what the patients actually care about in terms of their symptoms. And so we partnered with some nurses who are experts in qualitative research to kind of get at what are important to our patients right now in New Mexico. The interview guide was largely based off a KDIGO controversies conference that looked at sort of renal supportive care and the symptoms that were sort of elicited in that conference. We went over, I believe, all 13 of them with every patient, and we tried to get at how often they experience, how much it impacts on their daily life, and how they address these symptoms. The patients that we selected with a proportion sampling approach reflected the population of patients I take care of in New Mexico, and at least their numbers probably look similar to the patients you take care of here. The demographics are probably a bit different in that our population is largely, nearly half Hispanic, and about a third of them are Native American. I guess the striking things that came across in the 50 interviews that we ended up doing in this very diverse group of patients was fluid balance was a major issue. And, these are quotes from patients. In general, they relate many common troublesome symptoms to their fluid balance issues and fluid removal. And the patients themselves tried to address this by, cutting deals with the tech and the nurses in order to change what their UF targets were. And they also tried to control their own dietary intake. And this, to them, gave them some sense of control over how things went for themselves. The other thing that came up kind of across all patients was fatigue. And, I don't have a great sense on whether it's the post-dialysis fatigue or just fatigue overall. But in general, it was reported that associated with dialysis that they had a lot of fatigue. And in general, the fatigue was severe enough to interfere with their daily activities, like they weren't able to go out after dialysis, they didn't do housework. A lot of them would nap after dialysis. And the approach that patients took to managing fatigue was to try and work out what schedule they were on for their dialysis. Like for some it was morning, others in the afternoon or evening, in order to sort of mitigate the effect of fatigue post-dialysis. So in general, compared to the sort of list of symptoms that we culled from the KDIGO Controversies Conference, cramping and fatigue were a big deal to the patients that we spoke to. The patients had their own approach and would negotiate with providers on how much DUF or what time they would go on, but nonetheless, these still remain major problems. So, are the issues with fatigue and cramping and fluids related to the dialysis schedule that we use? This, in part, was one of the key rationale for the frequent hemodialysis trials. There had been observational studies demonstrating a benefit from frequent nocturnal and in-center dialysis. The putative effects of frequent dialysis, which Alan can tell you about better than I can, were improved volume management, nutrition, better blood pressure control, enhanced clearance of small solutes, and I think I took this from the brochure. There have been previous studies, one notably out of Alberta, demonstrating that frequent nocturnal dialysis had a beneficial effect on cardiac MRI. Of note, there was no change in the Euro-QOL 5D. The Euro-QOL 5D kind of grossly has like 5 questions addressing kind of all aspects of quality of life. With that instrument, no matter how you looked at it, there was really no impact of nocturnal hemodialysis on quality of life as measured by the Euro-QOL 5D. These studies in part, and a whole group of very smart folks, informed the design of the FHN trial, which looked at daily in-center as well as nocturnal dialysis and randomized the 2 studies were randomized with an active control group. The co-primary composite outcomes were LV mass as well as quality of life. And quality of life, it was in particular the physical health component of the SF-36. And this is the, the outcomes from the New England Journal paper looking at the FHN daily trial, demonstrating that there was a substantial benefit, significant and substantial benefit to quality of life from more frequent in-center dialysis. And that benefit, not only can be demonstrated using a time to event curve, but also if you just kind of look at the average scores, they were pretty clinically relevant size differences in quality of life scores between the 2 groups, with a change of around 3.2, 3.3. Of note, the differences observed in the nocturnal hemodialysis study were a lot attenuated. There was no substantial difference in change in PHQ score among the survivors in this study, and there's really no difference between the PHQ score between the conventional approach to the nocturnal arm. I just wanted to draw your attention to a recent study from one of my colleagues, Christos Argyropoulos and Mary Lena. They performed a systematic review of all the known studies looking at beta-2 kinetics in humans, and then they took what we know about the clinical trials we performed, short, like normal thrice-weekly dialysis using high filters or low filters, short daily, long daily, and then hemodial filtration. And what was sort of striking about this study was the marked impact of residual renal function. So if you're just focused on beta-2 kinetics, and I know beta-2 probably isn't the biomarker that explains everything in dialysis outcomes, but looking at beta-2, if you look at a patient with a residual renal function of 10 mLs per minute, there's really no substantial difference across any of these approaches because of the important effect of the residual renal function. There's only really substantial differences once you have a residual renal function of less than 4 mLs per minute, and that is shown in the top panels. So given the findings of the frequent hemodialysis network, it would make sense not only to do frequent hemodialysis in the center, but also to take it home and do it in the home. And I have to say, this figures from the NIDDK archives, and this is a patient doing dialysis at home, and he looks very formal. Maybe it's just that I'm from the Southwest, but I would be in my pajamas watching TV, but there he is doing dialysis at home. And the rationale to doing dialysis at home is not only is improved volume management, electrolytes, bone and mineral metabolism, but increased self-efficacy. The dialysis, one of the larger studies looking at home dialysis is using the Next Stage platform, and it's the FREEDOM study. In the FREEDOM study, it was a pre and post intervention study where they took patients who were largely on conventional thrice-weekly in-center dialysis and then put them on the Next Stage platform with roughly 6 times, 5 or 6 times a week in-home dialysis. And what they demonstrated among the patients that remained in the study, which is a little over half over the course of the year, that there was a pretty dramatic improvement in the physical health component score, or as they measured here, the PCS. So the physical performance of the patients who were able to remain on next stage over the course of the year increased almost more than double. If you look at the figure here where they go from baseline to month 12, there was really no substantial change, or the amount of change was not as dramatic for the mental health component score. Now, I guess in a editorial, we noted some issues with the design of this study and the limits that you should place on your inferences in a pre and post design. Because it may be that short daily hemodialysis at home really does improve quality of life. It really does make you physically able to do more. It may do that because of the increased number of first hours dialysis that you get with more frequent dialysis. It may be that you actually engage more support when you're doing dialysis at home. It may be the improvements in sort of volume control, the fewer medications that you need to take, or the observations of that study may be due to like the really strong selection bias, looking at patients who are able to remain on the platform for a year. It may be that it's hard to compare what would happen to these patients without an active control group that's going along with them. And it may be that the patients that drop out are different in some meaningful way compared to those that remain in. So, I thought that the Freedom study was a very interesting study, and it allowed us to say for patients that can remain on that platform and do daily dialysis at home that it's likely, not going to hurt them. But whether we can generalize that to everyone, I think, is a question based on that study design. So given what I've told you about thrice weekly hemodialysis and the limitations of that, and frequent dialysis and what seems to be a benefit of frequent dialysis, why would we even talk about doing less frequent dialysis? I mean, it really doesn't make sense, right? We should do more, not less. I guess, when you're thinking about less frequent dialysis, a lot of us will have patients similar to the patients you described, where they refuse to do dialysis and they do well. Likewise, we'll have patients that, maybe because of anxiety or because of the sense of control they want to have over their lives, they insist on doing twice weekly dialysis or even less than that, and some of them do well. In general, infrequent dialysis is done to conserve individual and societal resources. I've seen it in New Mexico due to a travel burden, of patients that need to go hundreds of miles for dialysis, and they just can't do it 3 times a week. Also, there are issues related to residual renal function that I think are interesting. It may be that we need to do a better job in hemodialysis of accounting for residual renal function when we think about the dose of dialysis. And it also may be that doing dialysis less frequently preserves residual renal function. It may be if you're doing less frequent dialysis, you mitigate the harms of the dialysis treatment. There's sort of emerging literature demonstrating sort of end organ toxicity from a dialysis treatment, perhaps due to tissue hypoxia. So, maybe less is more in this case. So who uses less frequent dialysis? In general, this tends to come from resource-poor countries. And a number of the groups in these countries have begun to report the long-term outcomes of patients on less frequent dialysis. The first bullet point is from Taiwan in a 7-year study using 23 patients who were on less frequent dialysis, comparing them to a matched control group. And they demonstrated that the twice weekly hemodialysis patients had a slower decline of residual renal function and used the hospital less. There was an early study actually done in the US using USRDS data by Hansen and John DeGeertis, I believe, is one of the authors, demonstrating that those that were doing twice weekly in the US generally had shorter vintage, were older, were more likely Caucasian, were more likely female, had a higher albumin, lower creatinine, and a higher EGFR at starting. In this group, the people that were on twice weekly actually had a significantly better survival. That survival, however, that apparent benefit was attenuated once you adjusted for the fact that they started dialysis earlier with a higher EGFR. Oh, and I guess the figure there, when I think about issues like less frequent dialysis, things that are sort of coming from resource-scarce places, I think of sort of reverse engineering and the benefits that we can learn, or the lessons we can learn from places that are resource poor. In this case, I'm showing a figure from Project ECHO, which is a sort of a telementoring system that was developed in New Mexico by Sanjeev Arora to help train up primary care physicians as well as PAs and MPs who are in rural communities to kind of help them manage chronic health conditions. The initial model was hepatitis C, and there was a New England Journal paper demonstrating that, using this telementoring approach, you could have outcomes similar to patients coming into the university hospital. Interestingly enough, I'm actually a participant in this Project ECHO, which is endocrine ECHO, and I provide sort of the nephrology consultation. Also interesting enough, they cut the picture so that I'm not in it. I'm going to have to talk to them. I don't know what was going on with that. Maybe I wasn't wearing a tie. So, of note, no one wears a tie in New Mexico. So, I think some of the more recent emerging data looking at the prevalence of infrequent dialysis comes from China, from the DOPS group. They demonstrated among patients in China that they examined compared to other nations, there was about 25% of the Chinese that were doing dialysis twice a week. Of note, also, a number of the facilities had increased comfort doing less frequent dialysis. Nearly 40 or 50% were doing less frequent hemodialysis treatments. What does dialysis look like for these less frequent patients? It's actually not much different. The session time is a touch more. It's an average of 253 minutes versus 240. The blood flow rate's the same. The number of catheters, the distribution of catheters are the same. In this cross-sectional DOPS study, comparing those that are on twice a week to those that are on 3 times a week in China, there were no substantial differences in quality of life as measured by the SF-12, the physical and mental well-being. And so these are patients that have been on this modality for a while, and they report quality of life using these instruments that's similar to those on thrice weekly. So, what do I take from this emerging literature? I think that there's a need for prospective studies. The studies are largely small, largely cross-sectional, and so it'll be interesting as DOPS is in China for a longer period of time to see how the patients fare prospectively. As you know, as you become aware of, there are barriers to this approach in the US. Your dialysis dose and your hemoglobins may not look as good if someone's doing less frequent dialysis. I would say that, one benefit of this is maybe for those of us that are in the hemodialysis arena that it kind of renews a focus on residual renal function, which has largely been overlooked. And, a pragmatic take-home for me is that, maybe I can have a little bit more flexibility with my scheduling of someone who needs to go to a wedding and they have substantial residual renal function. They might be able to slide by 1 week with 2 treatments and decrease my heartburn. So in general, I guess my message is that, the data on frequency suggests that we can actually take an approach of more personalized kidney care. Hearkening back to the message of the Lemke, we really need to focus on monitoring the fundamental outcomes of survival, quality of life, and functioning. We can consider tailoring our dialysis approaches based on the individual values and goals, and remember to factor in how they're doing with the residual renal function. And then, just doing the dialysis or the frequency of dialysis may not be enough. It might be important to think about the symptoms and comorbidities that these patients present with as well. There's Dr. Sukor, Kimmel, and I are working in the ASCEND study, overseen by Dr. Kleiger, with an ever-vigilant eye. Also already brought up looking at issues relating to sleep, fatigue, and anxiety. And, in the U.S., I think it would be a very interesting thing to think about studies of individual dialysis prescriptions. Like, could you imagine a patient who's initiating dialysis for one indication or other who has pretty substantial residual renal function doing well for 3 times, with twice a week dialysis, And then as his residual renal function or her residual renal function declines, increasing to 3 or increasing to 4. And, is there a place for using the sort of in silico demonstration of what will happen to their beta-2 microglobulin or their fluid status with these more frequent or less frequent treatments? So I think that that's someplace we could go as a field. So I want to thank you for your invitation and look forward to questions in a little bit.
Thank you, Dr. Unruh. Challenge you during the QA session, I guess. The next speaker who I would like to introduce, it was an eye-opener to me when I visited Japan. And the reason I did was their quality of life, the care they provide is quite different from we do in the United States. They have a large population of dialysis patients they take care of. And how fortunate I was when Dr. Funakoshi visited SUNY downstate, and then I was sort of traveling and I wanted to see his center. So the next speaker, Dr. Funakoshi, is currently the president of Nagasaki Kidney Center and visiting professor at the Nagasaki University Graduate School of Medicine, Nagasaki, Japan. He received his PhD in hematology and oncology at the University of Tokyo, Japan. He did a postdoc fellowship in B-cell signal transduction research at NIH. He has authored many articles and reviews in the hematology oncology field. Now, Dr. Funakoshi, a Nagasaki native, moved to his hometown in 1998, working as a manager and a clinical director of his own institute treating patients with end-stage renal disease. He has about 450 patients in his building. He collaborates in many clinical researchers with Nagasaki University, authoring articles in dialysis medicine. And what stimulated me to visit him was how they treat hyperparathyroidism. I mean, most of us know when they have tertiary hyperparathyroidism, most of our patients undergo this radical neck dissection, and most of the patients that I speak to, if they can't afford Sensipar, they can't take it, they said, "You're going to cut my neck off and join my neck back?" And I said, no, it's not so. But they refused to go through that surgery. So fortunately, they've been doing a procedure that enhances the quality of life and is much more easier. So please.
Thank you very much for introduction, Dr. Sagi. And thank you very much for the organizer for invitation to speak. It's a great honor for me to be here. It's showing. Yeah, here comes a quite cute Japanese cartoon. I'm the only foreign speaker. I'm from city of Nagasaki, the west end of Japan. The neighbor is Korea, and the neighbor is China. And it's far. It's a long trip to be here. But, I'm enjoying. Yes. Yes. This is my city. It's just famous for one of world 3 greatest night view, and in addition to my presentation title, I wanted to talk about dialysis medicine in Japan, and the organizers generously permitted me to do. So I'm going to talk about dialysis medicine in Japan, anemia and QOL, and secondary hyperparathyroidism and QOL. Then therapeutic strategies for secondary HPT, including ethanol injecting percutaneous ethanol injecting right into the glands to necrotize them. The outcome of dialysis medicine in Japan is reported to relatively good compared to other countries. This is from DOPS data. As you see, relative risk of mortality is significantly lower compared with US and Europe. The reason for this relatively good outcome in Japan can be explained various factors. I will explain one by one. This is our classical breakfast, and it's yours, but not now anymore. I love hamburgers, and you eat sushi, so food is not the issue. Bushido means swordsmanship, representing character, part of the character of Japanese. We're patient and loyal and modest, so that these character or nature can affect dialysis adherence and may bring a better outcome. By the way, he's Tom Cruise in the movie Last Samurai. He's not the Japanese. Well, it's very hard to change our nature, but psychological approach may work. This is a great paper Dr. Suzuki and downstate colleagues had published 2 years ago in JASN. The Japanese investigators are surprised and almost shocked because not the message itself is a psychological approach works, but the way Dr. Suzuki did was the method was very sophisticated, and the impact of the on the QOL and fluid adherence is great than we imagined. Okay. As far as technology, this figure tells that more than 80% of institutes in Japan use dialysate with undetected levels of endotoxin and bacterial numbers. But now the water purification is developed in most of the country. So the technology is not the issue. Fistula, I think Dr. Kleiger mentioned, is one of the big factors which affect the risk of death. It's from JASN paper comparing native fistula or graft versus central venous catheter. Fistula has better survival. And this is from the DOPS data showing that graft provides better survival than catheter. And this is in Japan. Dr. Klager mentioned that 60% of US patients are treated with native fistula. But in my country, 90% are treated for the decades. That doesn't explain the outcome of our dialysis medicine. And cost and national budget for hemodialysis is maybe a big factor. Our government pays $4,000 a month, $50,000 a year per patient. And that results in 2.8% of national health budget is used for 0.25% of dialysis patients. That's a big point, the big factor. It might not be a big issue how much the government pays. It's a big deal how much you pay. Out of $4,000 a month, our universal national health insurance covers 70%. You still have $1,200 a month, but these system that you don't have anyway covers most of the fee, and eventually patients' payment is from $20 to $40, depend on your income. It's no exception, and it continues for entire your life. Suppose you're Mr. Trump. He pays $40 a month. That's it. Okay. So I think the people feel economically secured, which bring them the safety and better survival and QOL. And on the contrary, kidney transplantation in Japan is very immature. You have 70,000 transplantation a year, and we have only 1,500 per year. That result in your waiting period for kidney transplantation is 1 to 6 years. I'm cited from West Coast data, but Dr. Friedman said that in New York it's longer than 9 years, which does not surprise me. In Japan, the average is 15 years, and it's incredible. So it's very big shame. We are working very hard to develop the kidney transplantation system, but the fact that your kidney may never come may make the patient's attitude focusing on what they have now. It's sad though. So in my opinion, the relatively good dialysis outcome in Japan can be explained by dialysis adherence, native fistula, plentiful of national budget, less self-pay of our patient, and less chance to get a kidney transplantation. Now I can start my presentation title. Actually, this is only one slide for anemia and QOL. not only the docs, but most of the investigators, nephrologists, had reported that appropriate hematocrit can bring vitality and QOL. Secondary hyperthyroidism and QOL. And this paper was published last year showing that PTH has a strong impact to diminish QOL, rather stronger than age or hemoglobin. And this is an interesting paper from Endocrine Journal. Their primary hyperthyroidism. So their renal function is normal. And this is the patient, the primary hyperpara. This is a control healthy subject. And this is after parathyroidectomy for the patient. Of course, no surgery for a healthy subject. By reducing parathyroid hormone, mental disorder and memory got improved with normal renal function. Therapeutic strategies for secondary hyperparathyroidism in dialysis patients include various approaches, but today I'm going to focus calcimimetics, Sensipar, and surgical treatment and others, especially percutaneous ethanol injection. Percutaneous ethanol injection therapy, PATE, for secondary HPT is first published in 1985 from Italy and developed in Japan in 1990s. It's effective for all pathological stages, from diffuse to nodular, and minimally invasive in general, and extremely low cost. However, it can cause pain, hematomas, and most importantly, paralysis of the recurrent laryngeal nerves, sometimes irreversible, requiring plastic surgery for vocal cord or even tracheotomy. Devices and procedure are on your handout. We started with flushing with minimum amount, 0.02 to 0.1 ml of ethanol, and confirmed jet echo within the gland. I will show you the movie later. We use Hitachi Aloka devices, but you should have similar devices for superficial injection or puncture. And we use 1 ml regular 1 ml syringe and regular 22 centimeter needle. That is very cheap. After you assemble the devices, it makes a pathway which the needle get in precisely, and it's fixed. This is ultrasound images. Left side color Doppler, right side plane, and you see the dotted line, and the needle goes right on the dotted line. So what we do is the ultrasound technician find the parathyroid gland and then adjust the dotted line on the parathyroid gland. Left big black one is carotid artery, and the center red one is another big artery. But artery is not scary. We can see them and pulsating, moving, pulsating. But what is scary is laryngeal nerves. It's below parathyroid gland, and it's invisible. And the problem here is, as you see, laryngeal nerve runs right behind the parathyroid gland, and variation of that nerve is incredible in each person. I strongly recommend to doing this procedure by two person. Most important thing is to find the very good ultrasound technician. This is the gland, and you see the needle goes in, and ethanol injection making an echo, jet echo. Let's go on closer view. Patient's neck fully extended to get the better position to avoid jaw or clavicular. You proceed needle slowly, and I want to show this is 0.01 mil. The smaller dose, multiple injection is the safest way. This is not good example. We want to approach from the top of the gland, because the laryngeal nerves is below the gland. But it's okay. We made sure it's inside of the capsule. This is another troublesome example. Right top, there's we can see the needle. Needle is approaching, but we can see the needle or the tip, because the goiter, the hard nodule, is right top. So it bends needle a little bit. But yeah, we almost find. So the technician altered the angle of the probe to find it. Yes, it's inside. Yeah, I'm sure it's inside. So yes, inside. Flush. And how PAID works compared to SensePAR or surgery. There's no comparative study in Japan or elsewhere, because SensePAR came to Japan in 2008, and importantly, it's fully 100% refundable up to the present time. So using SensePAR is safer, and we don't lose money. So SensePAR almost driven PAID away in 2008. I downloaded effects of the SensePAR on serum PTH from pharmaceutical site. They titrated SensePAR to reach the appropriate level. Then next please. Yes. I made the figure from 3 different journals, all the top journals, of effects of PAID on serum PTH. And next place. I combined 2 figures into one. So this is comparing SensePAR and PAID. It looks like up to 2 years since PAR, and PATE works samely. How about surgery versus PATE? There's no comparative study. So I cited 2 different journals in similar date, similar observation period, and similar number of the patient. The blue line is 50% remission, and yellow line is 5 years. It's like, yes, surgery works only when it's done successfully. And it is very hard to conclude, but PATE may works as samely. And importantly, surgery is very dangerous in terms of dissecting and under total anesthesia. Next slide, please. And the cost for PATE is incredible. Suppose you already have a machine and devices. It costs, click please, $277, which is cheaper than Big Mac for one PATE. I compared these 3 methods by the cost. Next one, please. Everybody, all the world had concluded that SensePAR costs more than surgery in the long run. In my country, average of SensePAR is 50 mg, so it exceeds surgery in 1.5 years. And PATE costs nothing. Okay. Like I mentioned, in my country, SensePAR is 100 refundable. That means the more SensePAR you use, the more money you earn. That never lasts that long. So that they will come when SensePAR becomes comprehensive, DPC. Then people look at the number 277. However, we have to recall again that it has this risk. And next, last slide, please. This is take-home points of PATE. We're not ready. We are not mature for these discuss these method about QOL. But I would recommend that if somebody are interested in PATE, why don't you start with injecting vitamin D, mexacalcitoriol. There are some articles, so there are evidence. And mexa is benign. I never heard that mexa may cause laryngeal nerve paralysis. So when you feel comfortable with echo and injection, then you start with ethanol injection, which is cure-oriented. So I would add, you need machine, devices, skills, and good lawyers. Thank you for attention.
Thank you, Dr. Funakoshi. So I hope we can have a quick question-answer session. I'd like to invite the members to come up, and Dr. Delano and Dr. Ranganathan.
My colleague, Dr. Briefel said, could you imagine somebody with normal renal function driving maybe 45 minutes in New York City traffic, going to a dialysis unit, waiting about an hour for your chair to be ready, and then sitting for 4 hours watching TV? What would their quality of life be like? So, but Dr. Ure, everybody's talked about quality of life of hemodialysis and less dialysis, more dialysis, home dialysis. What about peritoneal dialysis? I know that wasn't the topic, but what are your thoughts on that?
I actually neglected to go into peritoneal dialysis. I would say that there was one of the slides from Bakewell reflected a population who's on PD, also showing decrements over time. One of the larger studies that compared PD to HD was a choice study in the US, and that demonstrated that, in particular, patient satisfaction was higher with peritoneal dialysis compared to hemodialysis. I think in part it's because PD patients have a completely different experience and different expectations. So they're more likely to be satisfied with their medical interactions. Also of note, there was a recent article which, a slide that I hid from an English group looking at assisted PD in England, and they compared of their older patients, I think they were largely over 75, they had about 130 on assisted PD and 130 on in-center hemo, and they compared the outcomes of the two groups, and they're pretty similar, suggesting that when you think about frequency, you should also think about modality, even in your older patients.
Dr. Funakoshi mentioned about pure ethanol injection and compared it for $2.77, which about 3 to 29 for MAC, I should say. I'm not sure, I visited Japan 6 times, I should say, and I used to have the same breakfast as we mentioned, except I don't take meat, so I'll just remove the meat and eat whatever it is there. But in Japan, you also use charcoal, right? Cremazine.
Yeah.
Could you comment about that, please?
It's a different issue from PTH, but he's saying we're using charcoal particle to absorb uremic toxin in intestine. Okay, and she mentioned bacillus, and that's very sophisticated. Our method is just drinking charcoal, and it costs costs $100 a month. So maybe yours are much cheaper.
You can buy a pound of charcoal for about $5. The same thing costs about $300. And the other hand, I don't know whether you have noticed that depends upon how the hemodialysis treatment is given, the surroundings is given. In the case of home dialysis, as they just mentioned, the people have less stress, less anxiety, I should say. So my feeling is that you have a better outcome of a quality of life when you have home dialysis, I should say, and rather than the regular hemodialysis.
Any questions from the audience? Yes.
Sure.
Was that a question? You could. Yeah. Can you hear him in the back? Okay, so, all right, he's saying the topic of erythropoietin resistance and anemia.
So, yeah, when the topic on erythropoietin resistance, it illustrates something I've always thought is important, but it is not being emphasized, that there are a lot of hematopoietin ingredients that can actually most likely erythropoietin requirement. I don't think we've been paying good attention to it because they are not necessarily economically viable. I mean, if you give IV iron therapy, you can reduce erythropoietin. Erythropoietin itself is expensive. But what about folic acid? What about copper? You know, we learned all of this in medical school, that they are also important. And studies are not being done to address this issue. So I was happy that, you know, you are bringing up the idea of heavy metals and the importance, you know, in terms of how it could reduce erythropoietin requirement. I've done a study, you know, whereby I actually give folic acid in a crossover trial. Give folic acid, you know, to half of the patients and then placebo to the other half of the patient. But the clinical outcome was erythropoietin requirement, you know, was reduced in those who received folic acid. And I'm surprised, you know, that, you know, there is not so much attention, you know, that is driven on this. So if you have any experience with regards to folic acid and erythropoietin resistance, you could share it with us.
I can't speak to folic acid specifically, I'm sorry. But I'm glad our interests are overlapping in that you think it's important. As a chemist, it's always reassuring to hear from the medical community that the questions that we're working on are really the questions we should be working on. So thank you. And then just more generally, I think there's a lot that we don't understand about metabolism. There's a lot of complexity out there. So even just in those 14 metals we mentioned, there's a lot of biology going on that, while we know bits and pieces of it, we don't necessarily know what the emergent properties of it are. That really drives my interest in metabolomics, and in particular, it has the opportunity at identifying places where nutritional supplementation, like you just mentioned, could really have an important effect, and we just haven't seen it yet.
We'll take one last question.
Dr. Unruh, the Food and Drug Administration reviewed most of the quality of life studies that were done more than 5 years ago and judged that they were inadequate to answer any real questions about efficacy. It's awfully hard to plan randomized controlled trials in dialysis. In the absence of randomized controlled trials, what can we do to convince organizations like the FDA that you have believable results with quality of life studies?
So I think when they were reviewing the studies, they were judging the science of those studies, not necessarily the outcome of patient-reported outcomes. And I think that was a limitation. I mean, the classic example is the Bierstein article, which was a study, a pre and post study of anemia treatment demonstrating an improved quality of life with the treatment of anemia. But given that design, you're going to draw a lot of inferences which may or may not be true. I would imagine that if you were looking at patient-reported outcomes, like any other outcome, it's the strength of the study design. To me, one thing that may be interesting, and it'll be interesting to see how the FDA handles it, is the focus on big data. And so as a healthcare system, we are working on getting our patient-reported outcomes into the EHR, as is everyone, right? So, our group and others will have access to the patient-reported outcomes of millions and millions of people. And so whether the FDA would buy inferences from big data versus, the small cohorts or the pre and post studies, I think will be an interesting question.
All right, we'll have one last question for Dr. Kimmel.
Thank you very much. It's for Dr. Gooding. It's a comment, very short, and a little question. So the AKI study suggests that pyruvate might be different between the groups, but one would hesitate to talk about AKI as being the cause in the absence of evaluations of acidemia.
in both groups, because those are powerful changes in pyruvate metabolism, beta-hydroxybutyrate metabolism, everything else. So it illustrates sort of the difficulty of interpreting big questions when you're looking at two groups. And that's my real question, because I loved having a statistical analysis first as a prelude to your talk. Very exciting, very provocative. And I'm wondering, rather than using principal components analysis, when you're doing discovery sets, maybe latent class analyses would be better in order to separate, where you don't have to provide the orthogonal characteristics. I wonder if Ms. Ritchie could comment on that?
She's probably
You got a nice statistical question there.
And you are, of course. The thing that has been a challenge in some of the early metabolomic studies is sample size. So now that we're starting to get larger sample sizes, we can do more sophisticated modeling. So you're going to do latent class analysis? Yes, so we've sort of started to do that with our structural equation modeling, which we did using untargeted metabolomics data. Because it was on an environmental study, it wasn't a direct comparison. It was sort of the exposure went through the metabotype to the outcome. So yes, we're going to do more of that. So thank you.
I think this session is over.